Hello there, listeners. It's Susie Doo from the Australian Society of Anaesthetists, and thank you for listening to episode 109 of the Australian Anaesthesia podcast. It's where we talk about all things relevant to anaesthesia in Australia. I mentioned at the start of our last episode that I would take a few minutes to share some tips from what I've learned in my podcasting journey, in the hope that it also helps you with your patients and your leadership journey and public speaking, because it certainly helped me with mine. Last time I talked about the late night FM DJ voice, and I can't help saying that without exaggerating the late night FM DJ voice. And in this episode, I want to build on that by applying it to how we introduce ourselves. In particular, I want to focus in on how we say our name. How I see it is that how you say your name really adds to that first impression of how people see you, whether it's in a social context or a formal meeting or standing up to give a presentation. And what I often see is the tendency for people to say their name too quickly or quietly because, of course, you know your name. But you've got to remember that your audience, we may not know your name. We may be thinking of other things, and this is our moment to first meet you. So by taking that time to say your name clearly and slowly, it can impart so many things like credibility, confidence, and just that you want to ensure that I know your name. So 3 things to consider when you say your name, whether you're doing it in your late night FM radio DJ voice, is say your name slowly and clearly. The other thing about saying it, and it also follows on from what I was saying about the late night FM DJ voice, is to put a downward inflection at the end. Doing so, and there's been a lot that's spoken and written about this, there's some experts out there in terms of vocal intonation, but doing so makes you sound more confident. There are certain cultures where they add an upward inflection in the end, and Australians, we tend to do it a bit as well. So what that sounds like if you're putting that upward inflection is, hi, my name's Susie Noo, rather than, hi, my name's Susie Noo. Susie Noo versus Susie Noo. If you say your name with that upward inflection, it adds this element of uncertainty. It sounds like a question, and you shouldn't have to ask a question about saying your name because you should know who you are. So that's the second thing. The third thing is that we tend to introduce ourselves, say our names within a sentence. So just say that sentence. So say, hi, my name is Susie Noo. Some people do other things like they say or put a click in, like a nervous click, because we're often thinking about something else, and you sort of expect, I suppose, that you're going to just punch your name out, but it doesn't always come across like that. So there's a real difference between saying, hi, my name's Susie Noo. That just adds this real uncertainty as to who I am, or it makes your audience, your listeners, think that you're uncertain about who you are. So if you're uncertain about who you are you going to be certain about what you're going to be talking to me about? The other thing I mentioned, clicks. Some people have a tendency to have a nervous click, so they might say, hi, I'm Susie Noo. So just try and take that moment to be very conscious about introducing yourself and how you say your name. And maybe since I've been doing this, I've been noticing, and maybe it's just because I'm getting older, or maybe I just sound bossier, I don't know, but I tend to get less patients mistaking me for a nurse or a registrar. And that used to happen a bit because I'm shorter, I'm female, there's a whole bunch of reasons, I don't know, unconscious bias, all of that, where often I might be with an older presenting male and it'll be assumed that they're the boss. But anyway, since I've been saying my name more confidently and with my downward inflection and slowly and clearly, my patients trust who I am, I suppose. So that's my talking tip for today, I suppose. Let's call them talking tips. Anyway, let's move on to introducing my next guest. And this episode is literally an oldie, but such a goodie. It's both an oldie because of my guest, no offense, Bob, but he is the earliest surviving past president of the Australian Society of Anaesthetists. I have to say earliest because there is actually Don Maxwell who's older than him, but Don was president after him, if that makes sense. So the guest I'm talking about today is Bob Hare. who was president for the ASA in the early 1980s. And that's as far back as we can go in terms of speaking to past presidents who are still with us today. It's also an oldie because I recorded this episode a few years ago. I've only published snippets of it before, but I was really inspired to publish the whole episode due to a recent conversation I had with Zane. Thank you very much, Zane, for your inspiration. Zane told me how much he liked the podcast. Thank you for that. And I asked which episodes in particular he liked. And he said he really enjoyed the 90th birthday episode. That one almost killed me to produce and edit, but I'm so glad that he said that. But he said that he really liked the history-focused episodes because it just gave a really good context to Australian anaesthesia. And it was also for him a really nice break from studying for the first part exam. So I really love that it was someone at the start of their career really enjoying some insights from people who are happily in retirement, but who have also just given so much to what we now call anaesthesia in Australia. So there is plenty of history in this episode. We mentioned some big names in the world of anaesthesia in Australia, some significant men and women there. Bob and I go through having just this wonderful chat. We're comparing our various anaesthetic techniques that we have come across through our generations, some of the innovations that have occurred, and as well some of the changes in our role as anaesthetists and some of the important work that he and the ASA has done to raise the status of anaesthetists in Australia. It's always great catching up with Bob, and I'm sure that you are also going to really enjoy this conversation, and I'm really honoured that I can bring it to you. All right, let's get into it. Well, thanks for giving up some time with me this morning. I didn't realise that when I became president of the ASA that I would get to join quite an exclusive club, which is that of the past presidents. And it's been lovely getting to meet people like yourself. So I'm really delighted to be able to sit down and have a bit more of a chat with you and also just share our conversation with the public, with the members out there.
Thank you.
So you were ASA president in the early 1980s?
I was 81 and 82, yeah.
And you heard about Dave McConnell, didn't you?
Yeah, Dave McConnell died. All the presidents prior to me are dead, and some of them post me have also passed on, thinking of people like Ben Barry, Richardson, and...
I've had a chat with Don Maxwell. His podcast came out in time for the ASA's 90th birthday. And I was going to ask him if I had permission to share how old he is, because he's as old as the ASA.
That's right.
He might not want me to tell everybody.
I think you don't need to ask him about that, but I reckon he'd be happy to share it.
I miss seeing him at the president's drinks. He said he's just not getting so confident about heading out. And I normally see him at the cocktail function.
The president's cocktail function at the scientific meeting?
Yeah, that's the one. I don't know who gets an invitation. Do you get invited to that?
I get invited to just about everything, and for obvious reasons I can't come to them unless it's here. But no, there's a president's cocktail party at the scientific meeting. I started that because I was concerned that overseas gurus had come, and it'd often be only one person, a hugely gruelling schedule where they had to go to each of the states. At that meeting, they would get emballed up with the bright people who were doing research and never get to know the people who'd done the hard work to organise the meeting. So I thought it would be a good idea if we started that. So we started that in about 1980.
That's a great legacy. And I think it's wonderful because you're right. The organising committee are invited, the board and the council and all the invited keynote speakers. And it's just this great meeting of people. Wow, great. Well, thank you. Thanks for starting that tradition.
Yeah, one of the few things.
I thought today, if it's okay, I might ask you about what anaesthesia practice was like in your time.
That's an interesting question. Yes, anaesthetic practice in mind. I'll tell you, I gave one ether anaesthetic just with a Schimmelbusch mask just to show that I'd done it. But one of the huge benefits, of course, was not only thiopentone but propofol. And propofol's made a huge difference to people and patients and how they feel about anaesthesia. We didn't have pulse oximetry. We didn't have capnography.
What time frame is this?
Well, I'm talking about when I started giving anaesthetics, which is 1962. I graduated in 67. That's what we were doing.
So you trained without pulse oximetry?
Oh, our pulse oximetry came in years and years later. We monitored with the finger on the pulse and blood pressure, and that was it. various others developed a little pulse meter. So you stuck it on the finger and it'd give you a blip. We didn't have computer screens on anaesthetic machines. The drugs were not as specific in their actions as they are now. For instance, muscle relaxants were not as easy to use. They became more and more specific to their actions with less side effects. That was one of the things. But as I say, pulse oximetry, terribly important now, and capnography were the province of the research lab for much of my time when I was doing it.
Oh, really?
And anaesthetic machines, the Boyles machine was a very good machine.
Oh, I like the Boyles machine.
Yeah. And then there were the developments. And I think, frankly, that the anaesthetic machine is over-engineered for the job that it's doing.
Oh, it's very complex nowadays, yes.
Well, young people probably wouldn't think that because they're very savvy with mechanical things and electronic things. One of my good friends, Ian Philpott, a very smart chap, thinks on his feet, retired from anaesthesia, he's now 90, and he said he'd like to know what a new machine was like. So I took him into the operating theatre and I said, Ian, turn on the oxygen. He couldn't turn on the oxygen.
It's so intuitive on a Boyles. You just have a rotameter, you have a dial, and you see it move. I agree. I actually made a video to explain to people how to start pre-oxygenating a patient just from how to turn on the machine, because there's about 3 buttons you've got to make sure that you push to get it all started.
So that was one of the differences. The other is improvements in pain management post-op. But also the chronic pain and the sort of things that the Faculty of Pain Medicine look after. I went to a meeting in New Zealand, ASA meeting, and there was a chap there, I think his name was Wright, who was a resuscitationist, and he gave a talk about intravenous use of morphine. I thought, well, this is good. You could actually put morphine into the drip for post-operative patients.
So this was a breakthrough.
Well, it was in a way. But what was even more was the surgeon I was working with had been involved in the dialysis unit. He did shunts for dialysis, and they were using a pump. It occurred to us that we might use a pump instead of putting the morphine into the drip, where the drip rate would be either dictated by the pain needs or the fluid needs. We started to inject morphine from a syringe into the sidearm of a drip. I think we were possibly the first people to do that, but not necessarily.
Wow.
But I think that would make a huge difference.
So before then, was intravenous morphine commonly used?
No, intravenous morphine was not commonly used. Post-operative management was fairly standard, so post-operative pethidine or morphine IM 4 to 6 hourly, which wasn't totally satisfactory. Many years later, we realised the importance of simple analgesics in combination with opiates for post-operative pain.
And then if you wanted to give morphine intravenously, was part of the fear, the risk of overdose, because you've got this mixed bag and these mixed needs of giving analgesia and giving fluids? The
risk of overdose, always there, of course. And the other thing was we had patient-operated syringes, so you could press the syringe and get a burst of morphine. Well, people started to think, well, that could have been addictive. But anyway, it was the early days of it.
So separating the morphine into a pump and having that separate from the fluids was a huge shift in how you could deliver morphine post-operatively.
I think it was. We also did some research and we had a professor of pharmacology who was able to do morphine assays. But that was helpful.
Just going back, you trained in Melbourne?
No, I trained in Adelaide, came across to Melbourne during my training and got my first part here. I don't know whether you want to know all this sort of stuff. We're just having a chat, aren't we? So, but there was an anaesthetist in Adelaide, Pop Daniels. I said, I want to be an anaesthetist. And he said, well, look, biggest hurdle is anatomy. A lot of aspiring anaesthetists and surgeons fail their anatomy exams. So I started studying anatomy. I really studied like mad, and to the exclusion, unfortunately, of my family, I think.
I think that goes for all study. The exams are hard.
Actually, I got the Renton Prize that year.
Oh, did you? Congratulations.
That was about 66 or something.
Oh, I didn't know I'm speaking to a Renton Prize winner. That's a hard prize to get. Well done, well done.
So that's how we practiced, and it was a challenge, probably more challenging in a way. But
I wondered, when I was in Cambodia, they gave me a small baby to anaesthetise for a PDA ligation.
Yeah.
And the monitoring there was an esophageal stethoscope.
Oh, wonderful. Good on you, Susie.
Did you ever use esophageal stethoscopes? Is that something that you're familiar with?
I have used it, but not a lot.
I can't say I could hear very much at the time. I definitely handed the stethoscope back to my colleague who I thought should have more say on whether this duct was closed or not adequately. You mentioned muscle relaxants, and you said they weren't as targeted as they are
Oh,
now.
they weren't just targeted. More side effects, particularly with tuberculin and flaxidil were the ones that we used. They weren't bad, but there were often side effects, particularly with tuberculin. You get hypotension, other adverse reactions. Well, now, the new one, what's the new one? It came out years after I finished, but very expensive.
In terms of muscle relaxants?
Yeah.
Well, we've got all the benzoyl-isoquinolones like atracurium, cisatracurium. I think you've Sigamidex.
That was the one I was trying to... Well, I couldn't remember the name of it. Because that was the other thing too. The duration of effect of, say, curare, reversing curare, and particularly if you're in a private practice, making sure that your patient was back in the recovery room so that they could get on to the next case. There was a bit of an art in that.
Oh, I can imagine.
To be able to work out your doses on when to reverse them was more difficult, I think, than it is now. But we're going back to the very early days.
Yeah, well, this is fascinating. We don't practice this anymore.
Pentothal was a terrific drug, but not as good as propofol.
And pentothal is the trade name for thiopentone.
Thiopentone, yeah.
I've used a little bit of thiopentone in developing countries.
Yes.
And it was, actually, when I trained, it was the go-to for GA caesarean sections. Not so much now because you can't get it anymore in theatres.
Actually, you're right. It went off the market, didn't it?
Yeah.
For good reason.
One of my thoughts is, and tell me whether you disagree or not, is that as anaesthesia has advanced, that has enabled surgery to advance.
Absolutely, no question about that. Particularly, we did very little surgery when I started. Why? Because there were huge risks then of anaesthesia. You didn't have an anaesthetic unless it was absolutely necessary. And then as that anaesthesia improved, and the other thing, given by specialists,
yes,
then a lot of other procedures ensued, and I do agree with that. But the surgeons would say, there's been a lot of advances in surgical technique, equipment and sutures, and I go along with that.
True.
But I agree.
You mentioned in your Geoffrey K oration, which would have been called the Presidential's Address back then.
Oh, geez, that was in Tasmania. That was years ago.
Yeah.
I wasn't very well versed at public speaking. It was nowhere near as sophisticated as a discourse as you would have given.
This is the benefit. I've just read it, so I can only imagine how you would have delivered it perfectly. But I want to ask you about the safety of anaesthesia, because you make a good point that you only did surgery and anaesthesia when it was necessary.
Yeah.
These procedures like cosmetic surgery just couldn't be done. With that, the mortality and the morbidity would have been higher than it is nowadays.
Yeah.
Were you aware in your practice or in your colleagues' practice of people who had patients die under anaesthesia?
Yes, things had improved by the time I started doing anaesthesia. I had a cardiac arrest in my first week.
Oh, jeez.
The surgeon was doing bowel surgery, and he opened up the diaphragm and started internal cardiac compression, as it was, and this patient survived.
Survived?
The patient survived. In fact, had I had more experience than about 2 or 3 weeks with anaesthesia, I probably would have been able to assess the patient better, but the pulse just went off, and that's all we had.
That's a really good point about the value of the preoperative consultation.
You give an anaesthetic for anything almost with impunity, but that comes on to preoperative evaluation, assessment of the patient.
Yes.
And this is something that I was very concerned about when I was president, particularly because for a number of reasons, Susie, anaesthesia wasn't as highly regarded and anaesthetists as they are now. I think anaesthetists and anaesthesia has got held in high regard. But then the medical profession, particularly the surgeons, and the public in general didn't regard our specialty highly. In fact, the public would often say, you're an anaesthetist. Oh, you're a doctor, are you?
Yes, we still get that, Bob. Maybe not often.
But on the other hand, as the influence of the ASA, the faculty and anaesthetists themselves became more apparent, people say, sometimes they say, you're the most important person in the room.
Yes, we like those people.
Yeah, that may also have come about as a result of a film that I didn't ever see, but it was called Green for Danger. I think it was a film about someone running out of oxygen in the operating theatre or something like that. But over the years, the regard for anaesthetists and anaesthesia has improved, and I think we've got sort of equal status with surgeons probably now. In 79 actually, Don Maxwell and I were appointed a subcommittee to review the Constitution. And one of the things that we did was to change the Constitution so that in order to be a full ASA member, you had to have specialist training.
Yes.
And people who hadn't could be associate members with all the benefits except voting. And I think that was probably one of the things that boosted our status in the medical profession.
Yes, I think so.
Getting back, did you want me to talk about the preoperative assessment too?
Yeah, I do. And I'm glad I read about it in your presidential address, because it's something that's come up in the last few years about the desire to remove the specific item numbers for the preoperative consult. I don't know the exact figures, but over 90% of initiation of anaesthesia items are associated with the preoperative consult item. So the argument was that, well, if it occurs so commonly together, why don't we just roll them into one and make it the one item number? Exactly. And in response, we said absolutely not.
No.
And we talked about how we, the ASA, really advocated for it to be a separate item number. And I frequently tell this story to people. And as I read your presidential address, I actually wondered if you were one of the key people at the table when these discussions were happening.
I wasn't. I just came in as president and I was chairman of meetings and all that sort of thing. The only thing I think I did that had a real impact was our preoperative number. I've forgotten what the item number was now, was in jeopardy. So Des O'Brien and myself flew to Canberra and spoke to the relevant health official, pointing out the importance of the preoperative visit, and it was retained, but I think it was in danger of being lost. The other thing is if it's lost, the status of the anaesthetist is lost too, in a way. He becomes a technician. Mm-hmm. And I think also for the patient's point of view, they need to be appraised beforehand of what's going on, introduced to the anaesthetist and made...
Oh, for sure. It's just good medicine.
Yeah, put at ease about anaesthesia, because a lot of people still in this modern age are concerned about the anaesthetic and the surgery. Not surprisingly, at one point I had a patient who had indicated that she was terribly scared of being put off to sleep. So what I did is, look, come in to the hospital and we'll get into a theatre that's not being used and we'll do a dummy run. She came in a few weeks beforehand. I hopped her on the table, I put a blood pressure cuff on her and then squeezed a bit of skin. So that's about what it is, and she was eternally grateful. In fact, she wrote me a letter after the surgery, one of the few letters you get, but it is nice when you get a letter to thank me for that.
Oh, that's lovely. How did you find yourself becoming president? What was the steps?
Actually, I tell you, the genesis, I belong to the anaesthetic group in Melbourne, and Herb Newman was secretary of the Victorian section of the ASA. And one day he said to me, would you like to take over as secretary? And I said, no. He said, well, you will. So I became...
Voluntold, I say now.
Yeah, press ganged into it. And so then I became, by virtue of the way things go, chairman. And then we were flying over to Perth for an ASA meeting, and Kester Brown came up to me, he was in the plane too, and he said, you're going to be president of the ASA. I said, oh, thanks, Kester. Don't know why. What qualifications, except for two things. One, I was chairman of the Victorian section, and also presidencies then were rotated through the states. So it was going to be Victoria's turn. So in Perth, I was made president-elect and went on from there. I'm very happy that I got involved in ASA affairs too, I've got to tell you that.
Well, that's good. What do you think's been your highlight being involved in ASA affairs, either as president or before or after presidency?
Oh, gee, that's hard to say. Maybe having some influence, particularly, as I say, in the status of anaesthetists. I don't think young anaesthetists have to worry about that anymore. I mean, they're very cluey people. You've got to do very well to get into medicine first for a start and then to get into anaesthesia. In a way, you're seeing the ASA flourish, I suppose. Well, particularly from the sort of thing that you've done is outstanding, I might say that now. When I started, whatever state the president was in, somebody would be the secretary, a working anaesthetist.
Oh, yeah.
And they would put out a newsletter and do all that sort of thing. And then they decided, Ben Barry was one of the pushers of this, that there should be a paid secretary. So that was Sue Butterworth, and that was in 1970. And she worked from Elizabeth Street, which was the rooms of the first anaesthetic group in Australia. But even still, the Secretariat was actually one of those spandex folders with all the stuff in it. It's amazing how the ASA is now. It was a pretty amateurish setup then. With computerisation, with mobile phones and all that sort of thing, the ASA have taken this and used it for communicating with patients, of course, and members of the ASA. And there are so many things going on with the ASA. When I have a glance at the magazine, that's been marvellous. I think it really is working very well.
It is. It's going from strength to strength, which is great.
Oh, I think so. Well, an interesting thing is I'm not sure when it changed from the annual general meeting to the scientific meeting, the name. But the AGM, people spoke and they gave a talk in front of a microphone, and that was about it. Then as anaesthesia became more and more specialists who were scientists, researchers and so forth, things improved to the point where you didn't get much out of a single person talking. Some were good, others weren't. And then came sessions, the way of break off for sessions and all that sort of stuff. And then, of course, PowerPoint made a huge difference. It did, it really did.
Yes, true.
PowerPoint and computers. And another thing that I thought about was communication. When I was, for first, about 15 years, I suppose, if you were on call, you had to be at home so that the surgeon or the hospital, usually the surgeon directly, and particularly from private practice, could contact you on your telephone.
Of course, on your landline at home.
That's a landline.
Yes.
And then I wrote a history of the Melbourne Anaesthetic Group, and I was just looking back at that. And in 1978, we had the licence for a radio paging station at our rooms, and that allowed us to have pagers. So you could actually leave your home, the pager would go off, a surgeon would leave a message, and then you either went back home somewhere or whatever.
And that was the late 70s.
1978, we got our radio receiving station. Then the mobile phones came, and the first one was a sort of huge thing. They call it the brick. And then, of course, with mobile phones, you could do anything. I mean, you're on call, you could be at a restaurant, or you could be doing 101 things and still be on call. So it relieved things enormously.
Oh, that's revolutionised at least your social life when you're doing a lot of on-call. I didn't realise you were on the WFSA for so long. Tell me what that was like.
Oh, Susie, I mean, it was a wonderful thing to be doing, possibly the highlight of being involved in anaesthetic affairs. You've had a huge influence in affairs in ASA and get involved in a lot of things. But it enabled quite a lot of overseas travel. And Kester Brown sent me to Vietnam. That was interesting at a time when, of course, the bombing had ceased.
What time was this?
About 1980. So I took over some equipment there and gave them some lectures, but that sort of opened up your eyes to the world. Well, my eyes. Did you go to Laos?
Yeah, I've been to Laos a couple of times.
Yeah.
The hospital that I work with or volunteer with in Cambodia, they have a sister hospital in Luang Prabang.
The first person to go there that I know from Australia, I forget his name, terrific guy, Tasmanian, still gets involved in ASA.
Was it Hayden Pernt?
Hayden Pernt, that's right. I was secretary of the Asian Australasian section of the WFSA, and for some reason I was talking to Hayden, and he showed interest, and I think he might have been the first anaesthetist to go there, at least from Australia.
He's such a trailblazer. He's been and done so many things in
the
global health stage of anaesthesia. You said that Kester Brown sent you to Vietnam.
Yeah, Kester, he was the educational officer of ASA, I think. He didn't ever become president or anything like that, but we all know he had a huge influence in anaesthesia, both worldwide as well. And he must have been on the education subcommittee of the Asian Australasian regional section.
Ah, okay. I think he's tapped a lot of people on the shoulder.
Oh, I think so.
To get involved with global health, and he's been hugely influential.
Another one who's passed on, Susie.
Yes, very, very sadly. Did you know Kester well?
Oh, yeah, I had a lot to do with Kester. Yeah, of course. Well, I worked at the Kids Hospital in Melbourne, the Royal Children's Hospital, in 1965. We used to do 6 months at the women's, 6 months at the kids. And Kester, I just come to the job round about when I was finishing off there.
Wow. I think our careers shouldered Kester's, if that's a way to phrase it. So it sounds like you were a trainee when Kester first became director.
Yeah.
And I was a trainee doing the similar year, that third year of my training, doing paediatrics and obstetrics at the Children's Hospital. I did my paediatric rotation. And it was the year, I think, after Kester had just retired from being director or being at the Children's Hospital. So between you and I, we've shouldered Kester's career as director at the Royal Children's.
Oh, good. Yeah.
So there you go.
When I was there, John Stocks was still alive, and John Stocks and Ian MacDonald, as you probably know, were the people who pioneered the intubation of neonates.
Ah, I thought that was Margaret McClellan's.
Margaret McClellan was the boss, but she had left a couple of years before I came, and John Stocks was actually director. But no, it was Stocks and Ian MacDonald and Adelaide anaesthetists. They pioneered intubation of neonates. Prior to that, they'd have tracheostomies. And then John was pioneering recovery at the Children's Hospital. Greta McClellan, she worked out that the combination of trilene put through a CO2 canister on your Ball's machine could produce toxic gas.
Oh.
That was her contribution. Oh, that's the other thing I didn't tell you. We used trilene initially before halothane came in.
Yes.
Terribly difficult to use. Putting someone else to sleep with just trilene put a lot of people off doing anaesthesia, I think. It was terribly hard to use.
So when I was in Fiji, I had a Boyle's machine that had 4 rotameters on it. It had oxygen, air, nitrous, and trilene or trichloroethylene, I think it's called, isn't it? And then there was also a CO2 knob that you could turn on and off the CO2.
You turn it on.
The rotameters were broken. The interlocking system, it wasn't the interlocking system, the hypoxia prevention system. So I could, on that machine, had I connected trilene, I could dial up 100% nitrous and trilene and turn off the CO2 absorber. And really, if I were, knock off a patient very quickly.
But that's what they did initially, didn't they? That was a way of inducing anaesthesia.
Really?
Yeah, it was in America. Yeah, it's sort of hypoxic.
Tell me about this technique.
No, you'll have to look that up. I don't know enough about it, but that's what they did. Yeah,
really?
You almost asphyxiate them with nitrous oxide.
And could you dial up 100% nitrous? I mean, I thought there was that anti-hypoxic device.
Yeah, you could. No, you could do that.
Really?
Actually, the other thing. You've probably heard this sort of thing before, when I was the deputy director and I gave an anaesthetic for a young man having a nose operation. Well, towards the end, I, as we all do, turn off the nitrous and turn on the full oxygen.
Yes.
And he went blue.
Oh.
I was thinking, what are the ways that a patient can go blue? And so what I did was I tried to turn on the oxygen cylinder.
Yes.
Because maybe oxygen's not coming through for one reason or another. And anyway, I couldn't do that because the orderly who looked after the anaesthetic machine had the key to the oxygen cylinder in his pocket, and he was out having a smoke. So anyway, he got him in. The problem was it was a nitrous oxide oxygen switch.
Which still happens.
Which I'm glad that I was the first person to give an anaesthetic there, because, what had happened is that it was the first anaesthetic after the holidays, and during the holidays they had to service the suction. And the suction oxygen nitrous oxide came down in a single pennant that came down from the ceiling, and there wasn't any key to tell you which hole to put the oxygen.
So you just made it up.
Pipe and which one to put the... Anyway, John Mainland took that on and got things changed and coded.
Yes. And now we've got the index and the sleeve system and all those sorts of things.
And the other thing that's important is that the director of anaesthesia or some responsible person checks the equipment after there's been servicing.
Yes, absolutely. I did not realise that. I've learned something, that the Boyle's machine that I thought was broken was actually designed to deliver 100% nitrous. So it was the pre-anti-hypoxic device Boyle's machine. There you go. Tell me what trilene was like to work with.
Trilene, which was of course, an agent for dry cleaning. Did you know that? Yeah.
I remember one of them was a dry cleaning agent.
Trilene. Oh, actually terrific for getting stains off fabric and so forth.
I think it's still used, isn't it, as a dry cleaning agent now?
Yeah, I think so. It's got a nice smell and all that, and a blue colour.
Yeah.
But it was awfully difficult to induce a patient who put them off to sleep with thiopentone, and then to get them deeper with trilene was quite difficult. And it took quite a long while. And I know everybody had to do a bit of anaesthesia, all the residents. And it put some people off. They couldn't say, this is hopeless. How do we go about doing anaesthesia if it's all like this? When I was a student in Adelaide, the director of anaesthesia, a chap by the name of Marshall, I think he was a New Zealander, had a halothane vaporiser, but he also had a key to it so that he was the only person who could use it, turn it on and off. It was thought to be potentially very dangerous, but quite a huge difference to anaesthesia.
Wow. So halothane was thought to be too dangerous, and so everyone was encouraged to use trilene instead.
Oh, yes. But then, of course, it came into use because they realised it was a very valuable agent.
Can I take a little segue, Bob? What do you think the next 90 years might be like for anaesthesia in Australia, or what do you wish it might be like?
Well, in the next 90 years, hopefully we won't need anaesthesia in 90 years.
Wow.
That's what I'm thinking. I think anaesthesia, eventually you probably won't need it. So many things are now not requiring surgery. They're being treated in one way or another that's different.
True.
I would think they might be able to perfect electronic ways of keeping the brain anaesthetised and that sort of thing. Anaesthetists may not be around in 90 years. Oh, gosh. Will we be around in 90 years?
We won't be.
No, I mean humankind. It'll be totally different.
Good point, yeah. Do you think surgery will still be required?
Well, maybe not. It's so far in the future. They may be able to treat just about everything else by giving things, as you say, intravenously or radiotherapy or 101 things like that.
Yeah.
Susie, I have to tell you something that I've been thinking about the podcast.
Yes.
Something interesting that you may think about. And as I say, my thinking has mainly been on the status of anaesthetists and how it's improved enormously. I mean, I think the young anaesthetists are probably highly respected, particularly by the surgeons and the community as a whole. But I took over an anaesthetic practice from a group that had worked with a lot of surgeons from inner Melbourne. So I took over, and it was almost a ready-made practice. They were all older men, and they pretty well all had served in the Second World War.
Right. Were these the anaesthetists or the surgeons?
No, the surgeons.
Yes,
and the anaesthetists too, but the surgeons in particular, and which was all very good. There was one surgeon in particular, I didn't work with him very often, but they would have orderlies and people like that sometimes giving them anaesthetics when they're in the field. Anyway, there was one surgeon that, I can remember this, he'd be doing a bowel surgery, and then he'd say towards the end, before he was sewing up, you can turn it off now. He's used to ether and, wanted a quick recovery. Well, had I turned it off, you wouldn't have been able to sew the abdomen up, that's for sure. And at the end, I always gave anaesthetics with the left arm out on a board.
Yes.
And towards the end, after he'd finished, he'd throw off his gloves, come round, palpate the patient's pulse and say, "She'll be okay, Doc."
Oh, good. I don't think I've seen a surgeon feel a pulse for a very long time.
Well, that's what they did.
Oh, they learnt the hard way.
Yeah. Oh well, then there was a resuscitationist in Melbourne, East Melbourne, where we worked, who would come in and put the drips into patients on the requirement of the surgeon. And this guy had come in and fully, in his civvies up into the operating theatre, sometimes smoking, and then insert a glass cannula.
Wow,
well,
glass cannulas.
When you think about that, he was the guy who's going to have to do the resuscitation post-op. It was before we got involved, and anaesthetists would sort of come in and come out and not be involved in post-op. And the glass cannula would last.
Wow. So a couple of things I want to pick up. The term resuscitationist, when you say that, what do you mean? Well,
the people that would come round and resuscitate, for instance, this chap had a close liaison with the blood bank. And if a maternity patient, for instance, was bleeding a lot and, they could bleed and die, he would be there with the blood, put the drip in and get the blood going. That was the sort of what a resuscitationist was. Oh, this guy was invaluable.
So is this the makings of emergency medicine in a way?
Yeah.
And maybe ICU medicine?
Yeah. Well, then in private practice, not in public practice, in private practice, you couldn't really look after your patient post-op because you'd be in another hospital doing another list with somebody.
Yeah, true. And so they would help to resuscitate your patients afterwards.
Oh, yeah. In fact, in many cases, you wouldn't be involved with the patient after you left the hospital, the operating theatre. Not good.
Because that's a whole specialty or field that we don't have anymore. We don't have resuscitationists.
No, I suppose we. It's
the ICU resident or the.
That's right.
Emergency medicine specialist.
What I tried to tell anaesthetists over the years is, look, try and do all or most of your anaesthetics in one institution, whether it be private or not, and then you can look after them. Yes. Also post-op, particularly, I made a point of doing this for post-operative pain. I worked at one hospital for about the last 10 years and was able to get involved in that.
Exactly. I think us being involved in that perioperative medicine before and after is very
That's an
important.
interesting thing. Yeah, I would have. Yeah, that's very interesting, Piri. I must keep up with that and what's going on about that. But so anaesthetists could consider themselves well enough trained to be able to look after post-operative complications. Now, when I'm saying that, when I worked at the hospital doing bowel surgery, and I'd get involved with post-operative pain, but when something went wrong with the patient, then a physician would come along, it was the same physician all the time, and do the post-operative or perioperative management, I suppose. So I didn't consider myself well enough trained or had enough knowledge to look after somebody, for instance, who was going into cardiac failure or something like that.
Yes. I think it's changed now.
Has it? Yeah.
Yeah, I think so. I think especially when we come out of training, that's my theory, is we're like pluripotent stem cells.
Yep.
And I personally did a lot of ICU time in my training.
Yeah.
And so I was very comfortable managing an ICU kind of patient, stabilising them in order to get them to ICU.
Yeah.
And taking on that pre and post-op resuscitation if required.
So the young anaesthetist would be equipped to do all that.
I think so. And I think it's getting more complex.
It's great news because I think you need continuity with your patient, both before, which I've talked about, and after. I was happy to do the pain management, of course.
I think some are dabbling in it more. Things like people who are coming in on warfarin and having to swap the warfarin over to Clexane and then when to restart the warfarin. Like some anaesthetists will manage that. Some will hand it over to a perioperative physician. Some will do it in consultation. There's more options to get involved now.
So it's called perioperative medicine and it's not limited to anaesthetists then?
Yeah, true. I think the people who are doing perioperative medicine, there's, geriatricians, there's general physicians who are getting involved. The big studies looking at various outcomes from surgery are looking at common conditions like how aggressively do we need to control blood pressure and diabetes before people head into surgery. Physios, nutritionists, if you're having major cancer surgery, what's the best diet you should be on? What's the best exercise regime you should be on in order to get the best outcome from your surgery?
It's sort of evolving now, isn't it? Very interesting. That would be the biggest change, I imagine, since my time.
Can I come back and ask you about glass cannulas?
Yeah.
Did you use them?
No, I didn't, but he would have to do a cut down.
I see.
Very, very expertly and sew the glass cannula in. But obviously, as far as Dr Dreverman was concerned, they were going to last. Whereas a cannula, even our modern cannulas, they get clogged up and infection and all that sort of thing. Have you seen a glass cannula? I mean, they're tapered.
I've never seen one.
Then it's got to be sewn, tied in.
Right.
They'd be doing this with the patient asleep, of course, but that stopped when they realised that anaesthetists could do the job just as well or better. In fact, I probably think I would have given more than half my anaesthetics over the years without a drip.
Really?
Oh, yeah. Hell yeah.
Wow. It's like I teach my registers, like you'd always give an anaesthetic, you would always put a drip in.
No, unnecessary, Susie, for a lot of patients. And
the only exception was when I was anaesthetising children having radiotherapy.
Yeah.
They were the only patient group that I never put a drip in.
That's interesting.
That's so interesting.
One surgeon I worked with, who was the one who employed Dr Dreverman, the resuscitationist, he would order for post-operative fluid rectal water.
Oh, wow.
The water was introduced with a sort of enema bag into the rectum.
Oh, my goodness. And patients tolerated that?
Yep.
I suppose they did. Wow.
I'm too old now, but I think, I could give an anaesthetic for an appendix for about, I reckon the Pentothal was expensive, probably for about $2.
Wow.
No, £2. That's right, because when I started it was pounds. What would it cost to give an anaesthetic, apart from your fee, what would it cost to give an anaesthetic now for an appendix? $400?
Oh, more, I think. I mean, we were talking recently about the cost of Sugamidex, and I think it's just come off patent, but I think it was up there as a few $100s a vial for one dose. So we're talking thousands of dollars for any procedure nowadays. I think even just opening up all the single-use disposable things.
That's what worries me a bit. And We could go on and on, Susie. The other thing that did annoy me was disposable equipment. Oh, that one of the biggest, I think, advances was the laryngeal mask airway. I think it was a terrific piece of equipment.
Yes, true.
And you blew it up with a 20 ml syringe.
Yeah.
And there was a feeling at the hospital I worked that then you threw that syringe out because it was one only use. I mean, I find that criminal. I suppose it's the same.
Yeah. Oh, it's gotten worse. There's things like single-use tourniquets, single-use laryngoscope blades.
How can you just...
As my friend says, it's like you go to a restaurant, you put the spoon in your mouth. Yeah. You don't think it has to be a single-use spoon, do you? And where does the laryngoscope go, right? It's the same spoon.
Yeah.
Yeah, so single-use stainless steel.
Amazing.
Amazing's one word for it. Look, it's been great chatting with you, Bob. Before we go, is there anything else that you want to say? This has been a great chat. I really love just comparing our different techniques and things. It's been great.
Yeah, there is something. I think someone ought to do a podcast with you, Susie.
Oh,
you've got a lot. You'd have a lot of anecdotes and especially about your overseas work.
I love asking the questions. I'm actually not so great on the other end, but thank you.
Look, to be perfectly honest, I've had a lifetime of anaesthesia. I don't get involved in it anymore. You do that, you move on. But I have been reading, and I'm very impressed by what you have been saying in journals and so forth. I think you've done a terrific job, taking the initiative to do podcasts and that sort of thing. So,
Thank you.
Someone ought to get you and put you on a podcast. I'm happy to...
One day.
I'm happy to do something in conjunction with Jim or whatever you want, Susie.
That'd be great. Let's schedule another chat with Jim, and because I think when you guys get talking, I learn a lot.
Thank you.
Well, I hope you enjoyed listening to our conversation as much as we enjoyed having it. I think Bob and I could just natter on for ages. In fact, I know we have over dinner and various other events. I really love comparing our approaches over the years. He's probably thinking some of my techniques are crazy, and I don't know if I'm ready to give a regular anaesthetic without an IV. Anyway, I really love learning about how much the practice of anaesthesia has changed, and I find it really humbling, really. Dr. Hare talks about a time when anybody could give an anaesthetic, and I'm concerned because there are various people in decision-making seats in this country that would love to see a return to this. I'm talking task substitution here, especially in response to workforce issues that we're currently facing. And that's where a person with different, usually less qualifications, a non-specialist, perhaps even a non-medical person, is giving the anaesthetic. That idea is certainly being entertained, if not already undertaken in other areas of medicine. So who knows where we will be in the future, in 90 years, maybe not even within the next decade. But I know that for now, I and the ASA, the Australian Society of Anaesthetists, and the AMA, Australian Medical Association, on which I'm a federal council, we would like to see that healthcare continues to be led and overseen by medical professionals. And you hopefully will be seeing, or have already seen, some of the advocacy work going around tackling that issue. We definitely do not want to see healthcare overseen by insurance companies or even, as we're seeing overseas, private equity firms. All right, moving right along. If you enjoyed this episode, then 3 others that you might also enjoy are episode 90, as I said at the start. That was the special 90th birthday episode. It has been and probably will be the only episode where I interview multiple other people. It features ASA past presidents Don Maxwell, Greg Deacon and Mark Sinclair. So it's a bit of a president's fest and a unique look at the ASA, and not just the ASA but anaesthesia and the history of anaesthesia in Australia. Ultimately, I really enjoyed putting that episode together. It was great formulating a story, and I hope you enjoy how that all comes together. The other 2 episodes which might be of interest to you are episodes 85 and 86. These are my full conversations with ASA past president Dr Don Maxwell, who I mentioned at the start. He's, I dare say, the oldest past president to still be with us. And I broke up that conversation into 2 parts there, episodes 85 and 86. Dr. Hare very kindly suggested that a podcast with me might be of interest to some people because of some of the work that I've been doing overseas. If you want to hear more about the global health efforts from the ASA, then I have a whole playlist of podcasts. It includes updates from Fiji, Mongolia and East Timor. I haven't put one up about some of the work that I've been doing in Cambodia. Maybe that will come one day, who knows. They sit on the ODEC page of the ASA website. ODEC stands for the Overseas Development and Education Committee. And of course, I'll put a link to it in the show notes. Speaking of Cambodia, I've just returned from another trip to Cambodia and I'm often looking for people to join me. So if you are interested, you can find more information on that ODEC webpage. All right, I hope you've enjoyed our little ramble through anaesthesia history and onto global health. Thanks once again for listening to the podcast. Definitely feel free to reach out to me. I love your feedback. I love your ideas for future podcasts. podcast@asa.org.au is the best way to reach me. Until the next episode, I hope you stay well, stay safe, and be kind to each other out there.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists with many thanks to host and editor Dr Susie New, with music by Soda Lime Music, sound and engineering by Bearview, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.